So welcome all. I'm glad you're here. Just let me give you a little bit of introduction. This all started about 2 years ago. So those of you who were here 2 years ago, there may be some repeated material, but I think it's going to be advantageous for all of you to take a listen. 2 years ago, we talked about having various options in terms of deductibility of your incoming deposit as well as your monthly expenses as a medical expense. And that provoked the question by many of you, well, what are the medical expenses? How is this a prepaid medical expense? I know that when I signed up for a community such as this, there were included medical benefits, but I'm not quite sure what they were. So what we'd like to do today is run you through what the medical benefits and how you move through the continuum of our community and what you're entitled to, both from your contract and what are things that you might have to pay for on an out-of-pocket basis. Before we start, I'd just like Laura Barbieri to stand up so she's well known to all of you. Laura is the go-to person. So if any of this stuff we talk about today, you want to access, you want to understand how to do it, you want to know how to move through the community, you want to know what you're entitled to, what you're not entitled to, that's Laura. And I would advise you to send her an email or call her on the phone because she's never in her office. She's always working around doing something else. Okay, with that introduction, I'm going to turn this over to Chris. Chris has worked very hard on putting this together. There are a lot of facets. And then when we get through, I have a guest with us today that will try to help you navigate how to decide what kind of plan is best for you as a Medicare supplement plan or a Medicare Advantage plan, because this is the time of year when all of you have got to make a decision, and I've got a resource here that can help you. So with that introduction, Chris, you're on.
Thank you, Jack. Can you all hear me fine? Great. As you know, we were a little concerned today because we had taken 3 previous presentations and consolidated them to one and afraid it was going to be too long. So hopefully this is not too long for you. I timed myself this morning, got it done in 28 minutes. So we'll see if we can keep on that so we have plenty of time for questions for Laura, who's going to answer all the questions. Thank you, Laura. We have an agenda, just a quick overview of what a life care plan community is and what contract type we are. A quick review of Meadow Ridge's neighborhoods, how to move through the continuum of care and associated costs, hospital stays and the importance of status, short-term stays in a skilled nursing facility or what we call a SNF, Medicare versus Medicare Advantage, an important topic during open enrollment right now, life care days and their use, private duty aids, transportation, and question and answer. And so we'll start right off with our CCRC life plan community. Meadow Ridge is a continuing care retirement community, also known as a life plan community, and those terms are interchangeable. Meadow Ridge has what's called a Type A contract. While a Type A community is typically more expensive than a Type B or C, the higher levels of care, assisted living, memory care, and skilled nursing are provided with little or no increase in monthly fees. Type Bs and Type Cs, depending on their classification, you will pay market rates as you move through a continuum of care. And market rate in memory care in our market right now is about $12,000 to $13,000. So your life care rate is going to hold that solid for you as you move through. So basically, the resident with the Type A life care contract is prepaying for health care services that may be needed in the future, and there's more to come with that. Our 4 neighborhoods are independent living, traditional assisted living, mind and memory assisted living, and skilled nursing, also known as Ridgecrest. In independent living, we have 285 apartment homes, anywhere from an 800 square foot 1-bedroom up to a 2,600 square foot 2-bedroom, and everything in between. You live independently as you would in an apartment home or a condominium. While we provide access to healthcare professionals, such as podiatry and audiology and other services that are here independently, Meadow Ridge does not provide healthcare services to independent living residents. You may take a tax deduction, and this is very important for our new residents if you're unaware. Annually, we have a group of actuaries that are going to determine what portion of your monthly fees can actually be deducted from your taxes in the coming year because it is considered a prepaid medical expense. Some independent living residents choose to age in place, bringing in care from third-party providers as their needs change. And always remember the residents are welcome to remain in independent living if they are safe and appropriate. And depending upon your contract type, you may receive a rent reduction when moving to assisted living or memory care or skilled nursing. In our traditional assisted living neighborhood, we have 35 apartment homes, 17 one-bedroom units, 4 two-bedroom, and 14 deluxe two-bedroom units. Assisted living provides our residents with a broader base of support than independent living, but offers less support than a nursing home or memory care facility. As traditional assisted living provides 3 meals per day, housekeeping services, laundry services, and assisted living can also help with medications, bathing, dressing, grooming, ambulating, and transferring as is needed to the specific needs of individual residents. Our mind and memory care neighborhood, and you'll also hear us refer to this sometimes as our harbor, features 21 apartment homes, 17 one-bedroom and 4 studios. This neighborhood offers everything that traditional assisted living has and is designed for those who are living with cognitive impairment. The neighborhood is designed specifically for these residents and is secure, keeping them safe. Care and programming are tailored to each individual's needs, slowing the worsening of symptoms and deterioration of their current condition. The staff in mind and memory is specially trained to best care for their needs. Is a little supplemental information on assisted living and memory care. Thing to recall that both neighborhoods are assisted living, both are regulated by the state under our ALSA, but one is just specialized for memory care. Assisted living apartments are not furnished. If a resident fails to release their independent living apartment after moving to assisted living, they will be responsible for monthly fees in both neighborhoods. Both traditional assisted living and memory care are a residential setting. Assisted living is a combination of housing, managed residential community, or what we call the MRC, and healthcare, Assisted Living Services Agency, ALSA, also offering supportive services. And these services may include help with bathing, dressing, medication management, and activity planning. Our ALSA is licensed with the Department of Public Health and follows stringent regulations. We cannot, in assisted living, and that includes memory care, provide skilled nursing services per these regulations. As an example, our nurses are not able to assist with wound care. I know it seems silly. We have RNs in assisted living, and the regulations do not allow us to do certain services in assisted living. It would need to be done by a home care nurse coming in. As I said, it doesn't make much sense, but that's the regulations that we live with. A resident's health must be certified as chronic and stable by their primary care provider. To live in assisted living, any conditions you may have must be considered chronic, which is typically as ongoing, and stable, meaning it's well managed and controlled. A resident must be safe to be alone in their apartment. Residents must be able to participate in their care, which is scheduled, not on demand. Care in assisted living is scheduled care, meaning if you need assistance with activities of daily life, say that could be bathing or dressing in the morning, that will be scheduled on a daily basis. We partner with home care agencies and home health agencies to provide care to residents in their apartments. Home health agencies can provide therapy and skilled nursing, disease management and post-surgical care, fall prevention assessment, assorted therapy, nursing care, and wound care. And we partner with hospice agencies providing palliative care and end-of-life care, counseling and chaplain services, nursing care, and pain management. Then our last neighborhood is skilled nursing, which is named Ridgecrest. We have 62 licensed Medicare certified beds, private and semi-private rooms. Skilled nursing provides long-term care for individuals who cannot live independently due to physical limitations. They offer 24/7 nursing care, assistance with daily activities, meals, and medical support. And that care is always on demand in skilled nursing, meaning that it is not scheduled, it is as needed and as called upon. The facility's staff creates personalized care plans and ensures the well-being and comfort of all residents. Unlike assisted living, which is a residential setting, Ridgecrest is a medical healthcare environment, providing care or treatment that is considered skilled nursing, monitoring patients for rapidly changing health conditions, providing on-demand as opposed to scheduled care, 24-hour per day licensed registered nurses, a medical director who is a medical doctor on site, cardiologist, psychologist, and psychiatrist who round weekly, medical services of IVs, medications, treatment of acute conditions, wound care, x-rays, ultrasounds, phlebotomies, and EKGs. We also have a pharmacist, and we also have physical, occupational, respiratory, and speech therapists. So where do you belong? Well, you're here, so we're going to say you all belong in independent living right now. But what happens if something changes? Well, it all starts with you. If you are able, you have the right to make all decisions regarding your living arrangements, neighborhood, and care. Your family can and should be part of this decision. Our team, in consultation with you and your family, will determine what area is appropriate and shepherd you through the process. And that's where, wave again to everyone, Laura, that's what Laura does. And here's our team, and we lead off with the hub of the wheel, Laura Barbieri, licensed clinical social worker and director of resident and family services, and she is always the key and the go-to person for you. Next up is Paul Brown. Paul is our associate executive director and administrator of Ridgecrest. As well as being second in command for the entire campus, Paul directly oversees the health center, which includes Ridgecrest skilled nursing, traditional assisted living, memory care assisted living, and the EMT team. Loren Lent, registered nurse, is our resident care director. Loren oversees clinical operations in both the traditional and memory care assisted living neighborhoods. Adelino Barata is our mind and memory care director. Adelino manages the day-to-day operations of our memory care assisted living neighborhoods. And Briani Ganau is our new traditional care director. Briani manages the day-to-day operations of our traditional assisted living neighborhood. Most of you know Anna Fia Rosario is the director of nursing. She is the clinical lead in Ridgecrest, our skilled nursing neighborhood, and manages the nursing care team. And lastly is Deneen Capoziello. Deneen is the admissions director at Ridgecrest. She's the gatekeeper for anyone coming in there and will handle all admissions work for anyone who needs to go to skilled nursing. She's the point person and point contact, but again, you can always work right through Laura Barbieri. If you're in an acute hospital stay and there's potential for you to have to come back to Ridgecrest for care, Deneen will actually start following your progress in the hospital to make sure that she knows when you're going to be discharged, what your care plan possibly may be, and to make sure that she has a bed ready for you when you are discharged from the hospital. In addition to that, we have what we call our interdisciplinary team. Weekly, we have a tracking meeting. This group includes all of the health center team, along with representatives of food and beverage, housekeeping, activities, and fitness. They meet weekly to share observations and discuss residents who may have needs for assistance that are going unmet. This team may also include you, because this is a question we are asked frequently. How can I help as a resident? You may be worried about a fellow resident. Perhaps you've noticed a friend who has had a change in their condition. You can always speak with Laura Barbieri about your concerns anonymously. We're here to help. Residents should not feel responsible for taking on the care of another resident. That is what we're here for. If you've got something that's troubling you and you have a friend that you feel needs some care, let us know. Okay now, so who pays for what going through the continuum? Basic monthly fees, levels of care, and other charges. Basic monthly fees are the same as your independent living fees with the following exceptions. If you signed your contract before April 1st, 2021, the maximum fee would be based upon a Greenwich-style apartment. Those with a Windsor and a Saugatuck would see a reduction in monthly fees to the Greenwich price. If a spouse moves to assisted living, memory care, or Ridgecrest, they only pay the second person fee to the new neighborhood, while their spouse remaining in independent living will continue to pay the first person fee. So a couple where one has to move to a higher level of care, you will occupy 2 apartments basically for the same amount that you're paying right now. Other charges. Residents are responsible for all costs of moving their belongings to the new neighborhood. We can assist with a mover for you, and we're always happy. We always start with Laura Barbieri, and she'll direct you to the right person. But moving on, residents who entered into their agreement before April 1st, 2021 are responsible to pay for an additional 2 meals a day at $36 a day. Residents who entered into their agreement after April 1st, 2021 do not have to pay for additional meals, but are subject to charges for additional levels of care in assisted living if they are needed. As an example, in the past, residents would need to, if they were a 2-person assist, they would need to move on to skilled nursing. If you had a mechanical lift or you needed the help of 2 people at a time to ambulate, in the past, you would have had to have moved on to Ridgecrest. Now you can choose to remain in assisted living, but you would have to pay for that care. And that is all based on an assessment. And also, if a resident fails to release their independent living apartment after moving to assisted living, they would be responsible for monthly fees in both neighborhoods. And once you move through the continuum, residents are responsible, as you are in independent living, for all personal care and household items. So here's the process of moving through the continuum of care should that need arise. Step 1 is change. Typically, the resident is the first to notice challenges performing the activities of daily life, dressing, bathing, eating, and ambulating. This is expected as we age. Sometimes it is a family member who voices concerns about their loved one's condition to a team member. And other times it may be the interdisciplinary team that observes these changes, shares them during their weekly meeting, and then has a conversation with the resident. Step 2 we call discovery. Once a change is recognized or observed, it is time to discuss options for the next step. This is where Laura Barbieri typically steps in. Laura is the Schiffer for this journey and will lead our residents every step of the way. She will explain the options and the process and communicate with the health center team. Step 3 would be decision. Once a change is accepted and discovery is completed, it's time to make a decision. Along with the resident, this can involve the resident's family, friends, and personal health care professionals, your primary care physician, as needed. Laura Barbieri will be intimately involved to ensure that the neighborhood considered can meet the needs of the resident. Step 4 is the assessment phase. The assessment phase confirms the decision phase. Each neighborhood has regulatory requirements that need to be met for a resident to transition. Assisted living, again, requires that a resident's condition is determined to be chronic and stable, managed and predictable, and skilled nursing requires that a resident has demonstrated what's considered a skilled nursing need. Always want to make sure that you get to the right place where your needs are going to be met. Step 5 is always paperwork. For Ridgecrest, there's an assessment, a health center admissions addendum, and what's called a W-10 form from a physician. Legally, regulatorily, we cannot admit anyone to skilled nursing without a W-10 completed by a physician. We can do that using our medical director here as well for you. For assisted living and memory care, there is an assessment, an assisted living addendum, and that's it. And Laura Barbieri will guide you through this process. It's always Laura Barbieri, isn't it? Yeah. Step 6 is moving. Again, we have the assistance you need to guide you through this moving process. Laura Barbieri will work with Ann Rees, our move coordinator in the sales office, to facilitate your physical move to your new neighborhood and the release of your independent living apartment. Your family will be certainly involved, as your apartment in your new neighborhood will not be as large as your current home. So that's going to be probably the time you're going to make a decision to purge some items. While you're responsible for the cost of moving, Ann can assist you in planning And the typical cost for moving to assisted living is about $1,500 because it is all in the same building. Step 7 is acclimating. All moves are difficult and disruptive, and this one is no different. We have a dedicated team in place so that you're not going through this alone. From care to activities to dining, our team will learn about you and personalize your experience in our higher levels of care. And lastly, welcome home. It's important to remember that you've only changed neighborhoods, not communities. You are welcome and encouraged to continue to enjoy all the amenities that Meadow Ridge has to offer, which means if you move through the continuum, if you're able and you want to go to Bridge in independent living, or if you want to go to the bistro for dinner or the main dining room for dinner, or attend any of the activities that are offered in independent living, if you have the ability to do so, you absolutely may do so. It's not a segregated facility where you're gone and you can't come back. It's just changing what neighborhood within the community you're living in. Next area we're covering are hospital stays. Understanding your Medicare or insurance coverage for hospital stays can be confusing and overwhelming, often at a time when you are fragile and vulnerable. Status, inpatient or outpatient, affects your coverage and out-of-pocket costs. Don't be afraid to ask questions about your status. If at all possible, have a wingman, someone with you to ask questions and advocate on your behalf. Typically, that would be a family member or a spouse. Each day, you or your caregiver should always ask the hospital if you're an inpatient or an outpatient. And this is where this becomes important. You could be in the hospital and coming through emergency and be there for a day, even in a bed, and not have been admitted to the hospital. You could still be under observation status. It is only when you're formally admitted to the hospital with a doctor's order, the day before your discharge is your last inpatient day. Outpatient is when the doctor has not written an order to admit you to the hospital as an inpatient. In these cases, you're an outpatient even though you may spend a night, and I've heard instances of even 2 nights in a hospital without being admitted. And this is where this becomes important. If you're not admitted and you do not spend a 3-night qualifying stay in the hospital, Medicare will not pay for a skilled nursing stay subsequent to your acute stay in the hospital. So your status affects how much you pay for hospital services. Your hospital status also affects whether Medicare will cover the care you get in a skilled nursing facility. Observation services are hospitalized patient services you get while your doctor decides whether to admit you as an inpatient or discharge you. The decision for inpatient hospital admission is a complex medical decision based on your doctor's judgment and your need for medically necessary hospital care. An inpatient admission is generally appropriate when you're expected to need 2 or more midnights of medically necessary hospital care. Your doctor must order such an admission, and the hospital must formally admit you to become an inpatient. You must have a 3-day stay as an inpatient to qualify for a Medicare-covered stay in any skilled nursing facility. And this can be tricky. But we've got an answer for that coming up if you do not have that 3-day qualifying stay. So if you do get that 3-day qualifying stay, let's talk about short-term rehabilitation. We're going to have an overview of Medicare qualified stay, who pays for what, how long you can stay, and planning for your stay. Skilled nursing care is nursing and therapy care that can only be safely and effectively performed by licensed professional and technical personnel. It's health care given when you need skilled nursing or skilled therapy to treat, manage, and observe your condition and evaluate your care. You can only be admitted to a skilled nursing facility upon a doctor's order with a W-10, and Medicare will only pay for your stay if there's a documented need. So that's got to be ordered by the doctor with a W-10, and it's got to be a 3-day qualifying stay to have Medicare pay for it. Medicare will cover your stay if you meet these conditions. You have Part A and days left in your benefit period. You have a qualifying inpatient hospital stay, 3 days admitted. You must enter the SNF within 30 days of leaving the hospital and require skilled services related to your hospital stay. There could be an instance where post-acute, you actually get sent home. You're following up through your doctor, your condition's not improving, potentially deteriorating, and the doctor can still write an order for a skilled nursing stay, even though you have already left the hospital and gone home, but it's got to be within a 30-day window. After you leave the SNF, if you re-enter within 30 days, you don't need another 3-day qualifying hospital stay. This is also true if you stop getting skilled care while in the SNF and then start getting skilled care again within 30 days. This happens as well where a resident will be discharged from the hospital to skilled nursing. They'll go home and not be thriving. A decision can be made at that point either to go back to the hospital, which typically no one wants, or you do have the option of going back to skilled nursing at that point. Should you not qualify for a Medicare covered stay, you may use, and this is the great thing, what we call our life care days. And I'll get to that in a moment. So who pays for what at the skilled nursing facility? Medicare pays a semi-private room, meals and dietary counseling, skilled nursing care, physical and occupational therapy, speech language pathology services, medical social services, medications, medical supplies and equipment, and ambulance transportation to providers, or ambulette. Medicare does not pay for long-term care in a skilled nursing facility. It does not pay for private rooms, does not pay for most dental care and dentures, does not pay for eye exams or glasses, cosmetic surgery, massage therapy, routine physical exams, hearing aids, and exams for fitting them. Very clear and defined things as to what they will pay for and what they won't. And so how long can you stay in a SNF? Medicare may cover up to 100 days of care in a SNF in a single benefit period. Your length of stay will be based upon the progress to your goal. When your progress ends, so does your Medicare benefit. When your Medicare benefit ends, you may use your life care days, which we're going to get to. And remember that once you, in a skilled nursing facility, the object is to get you to your highest level of function as possible. Not necessarily to your prior level of function pre that acute stay in the hospital. And what is going to be happening is on a daily basis, they're going to be monitoring and documenting your progress, how far you're working, how well you can ambulate. And typically, once you hit what's called a plateau, even if that is not to your prior level of function, Medicare is going to determine that that's it, that you're no longer approving, and that can then trigger an end to your Medicare stay at a skilled nursing facility. That's why it's so important that when you're ever in skilled, that you're listening to your therapist and listening to your care team and working as hard as possible to increase your level of function. Because, again, once you plateau, they will stop paying for it. For days 1 through 20, Medicare pays the full cost of covered services. You pay nothing. For days 21 through 100, Medicare pays all but a daily coinsurance for covered services. You pay a daily coinsurance of $204 in 2024, and it can change each year. For days beyond 100, Medicare will pay nothing. You pay the full cost for covered services. If you have a Medicare supplement insurance, Medigap policy with original Medicare, if you have a Medicare Advantage plan, your costs may be different or you may have more coverage. So planning for your stay in a SNF, and which we hope will be Ridgecrest, always remember you have the right to go to the skilled nursing facility of your choice. We hope you're choosing Ridgecrest. The Ridgecrest admissions director, Deneen, will follow you in the hospital and plan for your stay at Ridgecrest. The hospital's discharge planner will take care of all the discharge paperwork to Ridgecrest. And if you're having a planned procedure which will require skilled care, contact Deneen to prearrange your stay. Or, as always, contact Laura Barbieri. Wave to everybody, Laura, so they know who you are. Next up is Medicare, regular Medicare versus Medicare Advantage. And this is an open enrollment period for Medicare. How many people have seen a television commercial touting the benefits of Medicare Advantage in the last hour? Because you can't go without it. Looks great, doesn't it? Yeah, they're being investigated by Congress right now. Just as a reminder, when you came here, in your contract, you agreed to keep Medicare Part A, Medicare Part B, and one supplemental health insurance policy or equivalent to make sure that any stay that you had in Ridgecrest was going to be covered. Because Medicare Advantage and Managed Medicare, they're a little difficult to deal with. In fact, very difficult to deal with. But they promise you everything, and then comes time to deliver. So what's the differences? Medigap, which is original Medicare plus a Medigap supplement. Higher premiums, but no copays. Freedom to choose doctors, no referrals necessary. Some routine services not covered, hearing and vision. And it's covered anywhere in the US. Medicare Advantage, generally lower premiums, but has copays. May be restricted to network. May need referrals for specialists. May include extra benefits, the hearing and dental. And emergency services only outside of your service area. And you need to get pre-approval on many things. And that's what we're going to talk about now. And this is what they're being investigated for. Denials. Each year, millions of claims for medical services are denied by Medicare Advantage. Denials may delay diagnosis and/or treatment for patients, and appealing denials contribute to clinician workload and burnout. Although Medicare Advantage plans are required to cover the same services as traditional Medicare, these private plans are allowed to leverage utilization management tools such as prior authorizations that traditional Medicare rarely uses. Medicare Advantage plans deny millions of prior authorization requests submitted. Although only 11% of these denials were appealed, the decisions were overturned in 82% of the appealed cases. The regularity of reversals has raised questions whether MA plans are deviating from their coverage obligations. It's been discovered that Medicare Advantage plans are employing artificial intelligence to deny care to residents who may need it. And what they found is that if they deny 100 people additional care, only 11 will appeal. And that means those 89 others, that's money that they put into their pocket. Remember this, Medicare is not a for-profit institution. It's paid for by your tax dollars. Medicare Advantage is private insurance, and there is a profit motive there. You have to ask yourself that everything that they get, all their money is coming from, Medicare. How do they make it all work? And one of the ways they do so is by denying coverage. There's a Senate investigation underway that found Medicare Advantage insurers are routinely relying on proprietary algorithms, man, I can't say that fast, as a basis for denying care. We don't know where this is going to go, but we know that they're going to be forced into a situation where they're going to have to hold up to their requirements, which is to provide the same care as classic Medicare. This is a great time to think long and hard about what you've chosen and how well it's going to serve you, and also to think twice about the commercials you see on TV. Don't believe Joe Namath, okay? Joe was a mediocre quarterback at best, okay? Sorry. Next up, so what happens if you don't get approved for a skilled nursing stay? What are life care days and how do they work? Every resident here has 90 life care days at the start of your residency. Life care days are for use by an independent living resident in either assisted living, memory care, or skilled nursing based on availability of rooms. Life care days allow for the occupancy of a room, apartment in either assisted living, memory care, or skilled nursing while keeping your independent living apartment. Life care days may be used as little as one at a time, in a continuous 90-day period, or in any combination thereof. To use life care days at SNF, a resident needs to be admitted with a doctor's order and the Ridgecrest team can provide that order. Life care days cannot be replenished nor additional ones purchased, so use them wisely. But in a situation where you've had an acute stay in a hospital that has not qualified for skilled nursing, you don't feel that you're ready to go back to your apartment, you can utilize your life care days to get a stay in skilled nursing. Perhaps your Medicare benefit has run out and they want to send you home from skilled nursing and you don't feel that you're ready. You want to extend your stay a little longer. You could use your life care days for that as well. As again, remember, there's 90 of them that you have when you get here, and to utilize those wisely. And that's what they're there for, those, for when Medicare or anyone else denies you your stay. Next up is private duty aids, general information, how to obtain and costs. A private duty aid, PDA, may be employed in any community neighborhood, independent living, assisted living, memory care, or skilled nursing. All costs associated with PDAs are borne by the resident. Some long-term care insurance policies may cover some of this expense. Check your policy. Medicare may cover the cost of a PDA in certain post-acute situations, though that's very rare. The community social worker, Laura Barbieri, can provide residents with a list of recommended agencies who we partner with. PDAs are typically contracted for time blocks as little as 2 hours per day, up to 24 hours per day. And live-ins are also available and typically have the lowest cost per hour. Rates started around, and this is where rates are going. When I initially wrote this, which was perhaps 2 years ago, that rate that I had starting was $20 an hour. That starting rate is now $30 an hour, and that is a starting rate, and can go higher. Live-in aids can be less expensive. A doctor's order is not required to employ a private duty aid. And please do not conflate or confuse a private duty aid with a certified nurse's assistant. A PDA, a private duty aid, can be a CNA, a certified nurse's assistant, but they are not required to be. They can be simply what's called a home health aide. And so they don't have any licensure that goes along with that. Next up is transportation. When it's covered, when it's not, and operations. Transportation home from the hospital is included in your monthly fees. Every effort is made to provide residents returning from Newmont's Norwalk and Danbury hospitals to Meadow Ridge with transportation by Meadow Ridge vehicles and drivers during normal business hours. Whereas these occurrences typically do not provide advance notice, Meadow Ridge transportation may not always be available. In these instances, alternative transportation will be facilitated by Uber, Lyft, or a taxi at Meadow Ridge's expense. Transportation home from the hospital not included in your monthly fees outside of normal operating hours of the transportation department. Alternate means of transportation are required, Uber, Lyft, or taxi. If you're getting discharged from the hospital after normal operating hours, contact the community. Security has set up a corporate account with Uber and with Lyft and can facilitate a ride home for you by Uber, Lyft, or a taxi service. So again, even though we'll not be using our transportation and it's off hours, we're still going to help you get back from the hospitals to Meadow Ridge. Security actually keeps an amount of cash, a petty cash bank, so they can pay for a taxi with cash if the need arises. And again, they have a great list of taxis now and a arrangement with Uber and Lyft. Transportation operations are open Monday through Friday. Hours are from 8 a.m. to 4:30 p.m. Offices closed on Saturday and Sunday. Minimum of 2 days notice required for appointments. Messages left after 4:30 p.m. will be returned the next business day, Monday for a Friday message. Bookings outside of normal hours are subject to an additional fee, and the phone number is 203-544-7733, and the extension is 522. And that was an awful lot of information in a very short period of time. I'm losing my voice. I should add, too, we're going to have the slide deck available, printed, at some point this week. And we're also going to have, Christine's done a recording, and this is going to be available on Cubigo. So if there's something you missed, you could pick up a copy of the slide deck, you could watch the video again, and we could also just put the slide deck up electronically if you want to see it that way.
Say one more thing about these, the 90 days, your availability of spending 90 days in Ridgecrest. These are for your use. Please use them. Don't save them. There are no luggage racks on a hearse. You can't take them with you. And so these are to be used. Obviously, you don't want to use them all up, but if you come home from a hospital or you have a specific acute situation, go down to Ridgecrest for a couple of days and let somebody help you through it. It's just very troublesome to get through on your own or put that kind of a burden on your spouse or partner. Okay, questions?
If there is an emergency in which I am not cognizant, I'm not able to converse, does somebody call my children? And marketing has those numbers.
Yes, in all levels, it's a little light. Can you hear it all right? In all levels of care, yes. In your IL apartment, you have a file of life that shows your next of kin and your notifications.
In that red envelope?
Exactly right.
Okay.
So if it's EMTs who are coming to you from our security department, and they're transporting you to the hospital, if you're not cognizant, they're going to immediately call, the person you've designated. Same thing if it happened in assisted living, memory care, or skilled nursing.
Thank you.
On one of those slides, the first statement was that Meadow Ridge would pay for Lyft, Uber, or whatever, and the very next line said that at patient's expense. Can you clarify that for me?
Yeah, if it's during normal business hours for transportation and we can't pick you up with one of our drivers, we will pay to transport you via Lyft, Uber, or taxi. If it's after normal operating hours, we'll still take care of it. We'll just put it on your monthly bill.
Jack, do we need a fresh letter for the IRS? Or is last year's letter still good?
You will get a new letter based on our actual activity somewhere in late January, early February, and it'll give you the same 9 options that you had last year. If you made an option, those of you who are here before last year, you've already made your election. The percentage may vary somewhat, a little bit, but it won't be big. But those of you who are new in the last 12 months, you'll be getting this letter for the first time, and we'll explain to you what your options are in terms of selecting an option that best fits your pistol.
If there's a choice, I'll take last year's percentage.
Well, that's not a choice. That's between you and the IRS and your God.
In Ridgefield, I believe there's an organization or a bunch of volunteers that are trained they know about these various Medicare Advantage plans and regular and they'll talk to you. Do you know if there's a similar outfit in Reading?
Okay, you're asking the essential question here, which is the end of this meeting. And I'll just do it now. Roger Palazzo is here with us today from the Georgetown Financial Group, which is right down the hill by the post office. What we're going to do when we get finished up here with our dog and pony show, we're going to let Roger say a few words about what his firm does, and he will make appointments with you if you're interested to go through your own situation in terms of which Medicare plan is best for you, whether it's a high deductible plan, a low deductible plan, whether you ought to look at a Medicare Advantage plan or not. So I'll be introducing Roger at the conclusion of this meeting.
Thank you, Jack. Really appreciate it, and thank you for everyone for your time here. My name's Roger Palazzo. All right. My name's Roger Palazzo. I'm a Medicare insurance agent. I work down the street at Georgetown Financial Group. We're a family-owned and operated general insurance brokerage, and I'm our Medicare specialist there. We're located right in between Reading Pharmacy and over by the post office, so I'm sure you've driven past there a bunch of times or gone down there a bunch, and it's nice to see some familiar faces here as well. So generally speaking, what I do is a lot of the stuff that Jack already mentioned, where we review clients who are on Medicare and try to find plans that are most suitable for them. So whether it's Medicare supplement plans or Medicare Advantage plans, and admittedly, we're a little bit more biased towards the Medicare supplement plans for a lot of the reasons that Chris went over earlier, and it explained them very thoroughly. But it's always good if you haven't reviewed your plans in several years, or in many cases since folks turned 65 and first enrolled in Medicare. Sometimes rates change, coverage options change, and there might be plans that might be more suitable for you. Something simply as common as, if you relocated from another state, the rates can vary from state to state, even though the plans are standardized. So that's some of the things that we look at just to make sure that you're not paying more than you really need to be for whatever coverage that you would like. And then something for this year that is coming up that I don't know if some of you have seen, I'm guessing you have, but some changes to your Part D prescription drug coverage. So there is a hard price cap coming into place on prescription drugs, which is good news for many of you. The out-of-pocket maximum is going to $2,000 in a given year. So for folks that are spending more than that, there is a hard price cap going into place next year. And I don't know if you know about the donut hole, but a lot of folks don't like that, and that is now going away for 2025, thankfully. So with that, there are plenty of changes to the plans. Premiums are changing. Some plans are consolidating. So if you had a notice of change and would like to see, is this plan still right for me, I'd be happy to speak with you about those as well. But yeah, overall, I'll be sitting outside after this meeting. If you'd like to stop by, say hi, sign up for some type of, free consultation. Our services are not fee for service. We're independent commissioned agents, so we're paid by the insurance companies at point of sale. So there's no obligation for any type of consultation. And with that, I'll hand it back to Jack, and thank you very much.
He is not paid for on a per diem basis or anything by us. He's paid by the insurance carrier or by the Medicare plan. So please feel free to contact Roger. Let him do an assessment of what your plan is, what things you might be considering changing in terms of a prescription drug plan or your Medicare supplement plan, and see if there's something that better fits your pistol. It's a service that I think is well worth checking into, because these are, I don't know if any of you have been on Medicare.gov or trying to look and figure out what plans are available for yourself, but it's a nightmare of a six-pack of spaghetti. So please do that. We've thrown a lot of material at you today. I hope it's been helpful. Again, we may have confused you more than we've informed you, but if you have questions, this is very important stuff, and please come on up and see Chris or Laura or myself, or please visit with Roger outside the meeting. And thank you very much for being here, and thanks for being so attentive.